want to make sure it's, yep, we got it. So every Choice Agenda webinar, we open the room up about 15 minutes early and have a playlist running. This is today's playlist. And this is today's run of show. I'm so excited to have Dr. Jenell Stewart with Hennepin Healthcare and University of Minnesota here to start us off with the presentation, Do Vaginas Demand Perfection? I saw Jenell present at CROI this year. She was one of the last sessions she was part of a session that was at the very end of the meeting and was interrogating PrEP myths and busting a bunch of PrEP myths. And it was just fantastic. And I've been kind of hounding her ever since to do this webinar. So I'm so delighted to have Jenell here today. And then a special treat when Jenell is done presenting within the next hour. We are going to be inviting the new co-moderator for the Choice Agenda, Anna Miti from Harare, Zimbabwe, will be on the line, and we'll be doing a virtual meet and greet with her. So getting to know a little bit more about Anna. We'll be taking your questions and comments. So I hope everyone can stay with us through the full 90 minutes today. But so excited to have both of these wonderful women on this webinar today. And with that said, I am going to stop sharing my screen, and I am going to invite Jenell to the virtual stage and go ahead and get it started. Thank you so much again, Jenell, for being here. You're very appreciated.
Thank you so much for having me, Jim. Let me just rearrange where people are showing up so I can see my slides. All right. So I'm Jenell Stewart, as Jim just graciously introduced me, and I am going to be posing the question today, do vaginas demand perfection? And this is really centering a conversation on event-driven PrEP, thinking beyond cisgender men. Oops. All right, so during the talk today, I'm going to be going through several things. I'm going to be talking about the importance of choice, having multiple PrEP options available and being able to choose between them. What is the data so far on event-driven PrEP? What is the potential impact of hormones on PrEP? And then talking about drug levels at sexual exposure sites, and then a little bit on alternative event-driven PrEP options. So to make sure we're all oriented and on the same page, I'm going to be talking about event-driven PrEP, and this has several aliases. Some people call it 211 PrEP, some people call it on-demand PrEP, and what I'm talking about is intermittent dosing of TDF PrEP, or tenofovir disoproxil fumarate, emtricitabine PrEP, and it is dosed a double dose, 2 pills, 2 to 24 hours prior to sexual exposure, followed by a single pill 24 hours later, and then continuing 24-hour dosing until 48 hours after your last sexual encounter. So we call it 211, but it can be 2111111, whatever people need to make sure that they are covered until 48 hours after sex. So right now, we are in an exciting era of HIV PrEP, where there are more and more methods becoming available. We're seeing new data on long-acting injectable PrEP, and there's lots of questions on why even talk about event-driven PrEP when there are these new methodologies coming out that are highly efficacious. And we know from decades of experience with hormonal contraceptives that choice and flexibility are incredibly important. Here's a figure from Malawi, population level over several years, and this beautifully highlights multiple contraceptive modalities that are being used and how that changes from year to year, with high levels of demand one year, changing to multiple new methods coming in and changing back over time. Thinking more at an individual level, from data in the United States, we see where multiple methods are available that there is no one method that reigns supreme. Some people need different things. And even within this pie chart, you can see people's primary method of choice in the year 2018, an event-driven contraceptive, or Plan B, morning after pill, barely made it onto the pie chart as people's primary method. But in addition to it being people's primary method, 23% of cisgender women aged 15 to 44 in 2015 have used this event-driven contraceptive. It remains an important component to how people approach prevention and family planning. I suspect as more and more PrEP methods become available, we will see similar trends. So why might someone choose event-driven PrEP over another option? In a trial that was done in the Netherlands, where primarily cisgender men who have sex with men were given the option of daily oral PrEP or a on-demand, the event-driven PrEP, people could choose which method they want, and then they were followed over the cohort. I'll tell you more about that later. But within that study, they did qualitative work and interviews, and they saw a wide range of reasons why someone might want event-driven PrEP over daily options. And this ranged from just wanting fewer pills in their life, or even just the ease of dosing, where it's more around what they need. Offering choice of PrEP method is incredibly important. And this is not just because it's the right thing to do to offer people autonomy over what is right for them, but we can also know from a study that was the search trial that was done in Uganda and Kenya that when people are given choice, the outcomes are better. So in this search trial, people were given the option of daily oral PrEP or a pill-in-pocket post-exposure prophylaxis. And you can see here in the blue bars when people are given that choice versus in the red bars when people are assigned a choice that people do much better and that the coverage is much higher when people are given a choice. Let's take a second to contextualize where we are today with event-driven PrEP. It does not show up on our CDC guidelines, and I think we need to take a historical view for why we are where we are. Around the world, we see different guidelines bringing forward different approaches to event-driven PrEP. To take a moment to talk about the United States and the CDC recommendations, I think this really does come out of prior experiences with the ADAPT trial. And the ADAPT trial was early days of PrEP trials around 2012 to 2014. And this was not true event-driven PrEP as we now know it. This was actually pre-post dosing. So they had to take a pill 2 hours before sex and 2 hours after sex. So a pretty rigid window there. And that was compared to weekly dosing, regardless of sexual exposure, and daily dosing. And they enrolled 347 cisgender men who have sex with men in Bangkok, Thailand, and Harlem, United States. And what this figure is showing you is coverage of sex acts. And the purple color that you see is that a pill was taken at a time where it would cover that sex act. When you see black, no sex happened, and so no PrEP was needed. When you see white, that was a missed opportunity for having that medication on board to offer prevention. With a quick scan of the eyes, you can see that the cohort in Thailand overall had higher coverage than the cohort in Harlem. And specifically looking at the Harlem cohort on the right, you can see much more white or missed dosing, lower coverage in the event-driven, the pre-post dosing, compared with the daily dosing. And this really hampered some enthusiasm around whether or not event-driven PrEP was a good idea when there was so much missed dosing. It's important to note that despite missed pills or lower coverage, there was only one seroconversion in this entire study across Thailand and the United States, and it was in a participant in Harlem who had been assigned to daily PrEP. And no surprise, as we've seen with other studies, that the breakthrough of HIV happens when there's non-use or missed dosing. And I think it's really important, and I bring up this historical example because I think there has been in the past a tendency to over-extrapolate when a certain population by ACE, by race, age, sex, or location struggles with taking an assigned medication as directed, that might not be an option for that entire demographic. And so we need to be cautious about over-interpreting studies and making sure that we are offering medications to individuals who would benefit from them. So let's talk about the evidence for event-driven PrEP. There has been only one randomized controlled trial, and that was a placebo-controlled trial prior to when daily PrEP was proven to be efficacious. And this happened in France, and it was among 400 cisgender men who have sex with men, and a few in Canada as well. And in this placebo-controlled trial, they showed high levels of efficacy, with only 2 breakthrough infections in those who were assigned to take event-driven PrEP, compared to 16 breakthrough infections in those who were taking placebo. The breakthrough infections were in the setting of non-use, consistent with the trials of daily PrEP. In this study, they had a median of 4 pills per week. So there's a lot of questions at the time about, is this actually measuring truly intermittent dosing of PrEP, or is it just imperfect adherence with 4 pills a week? And so there was a follow-up to this to kind of really understand, well, what about in the real world setting? What about when people have a choice and they decide which method is right for them? And so there were over 3,000 cisgender men who have sex with men and a few transgender women who were in France who were enrolled in the Prevenir study, the follow-up to this. And here in this graph, this figure on the right, you can see the choice between the event-driven in the orangish color, and then the daily PrEP in the bluish color on the bottom. And you can see over this nearly 3-year period, almost half of the cohort was choosing event-driven PrEP. Interestingly and importantly, 41% of this cohort changed method over the course of the 3 years to fit what was going on in their life at that time. And so it's not just about a choice that people prefer. Not everyone, but a percentage of people, a significant group of people prefer that option, but it's also flexibility in method and being able to go back and forth between methods to fit your life. Within this study, there was a median of 3 pills per week in event-driven during the times that people were using event-driven, compared with 5 pills per week in those who were taking the daily dosing. So this is really helping to tease that out a bit more. Within this Prevenir trial, they went further to look at coverage of events. And again, I'm using coverage instead of adherence because I think it's not, I think that there's times when people decide not to use their event-driven PrEP with a certain partner. And so we're specifically talking about coverage of sex acts. So in the column, column on the left, those during the times when people were taking daily PrEP, there was a 92% coverage, compared to during the times when people were taking event-driven PrEP, and there was 78% coverage. However, and this is why it's important to think about coverage versus adherence, there was no difference in the incident HIV that was breaking through either of these arms, and both were in the setting of missed dosing, both with the daily and with the event-driven. After that, there were many studies around the world that provide real-world evidence for event-driven PrEP, primarily among cisgender men who have sex with men. You can see here cohorts in the Netherlands, Belgium, Taiwan, USA, and a larger cohort in West Africa, where people were all given the option of, would you like event-driven PrEP? And we saw a range of uptake across these cohorts, ranging from 12% uptake to 74% uptake. And we saw highly effective use. Among those who decided to take event-driven PrEP, we saw no cases of breakthrough HIV except for the cohort in West Africa, and I will talk about that in a moment. You can see high levels of coverage ranging from 67% in Belgium to 96% in the United States. But focusing in on this West African cohort, this needs to be contextualized. This happened in the setting of no prior PrEP availability. So in a setting across multiple countries where there was no PrEP available, suddenly people had the option of, do you want daily or on demand? And the majority, the 74%, decided to take the event-driven PrEP. And actually, there was no difference between those who decided to take event-driven PrEP and those who were taking the daily, but it was such a small percentage of people who were using daily that really what made it so that you couldn't power a difference. And importantly, when you compare to the period before any PrEP was available, there was a dramatic decrease with an incidence of 2.7 to 10%, 2.7 per 100 person years when people now had access to event-driven PrEP, compared to without PrEP, where it was 10. What about people who are assigned female sex at birth? I've talked a lot about studies among people who were assigned male sex at birth. There's very little data for people assigned female sex at birth. Going back to the ADAPT trial, where I had just told you about the cohort in Thailand and Harlem, United States, there was also a cohort of cisgender women in Cape Town, South Africa. And again, people were assigned to take daily, weekly, or that pre-post dosing. And similar to what was seen in the Harlem cohort, there was a decreased coverage of sex acts with people who were taking the pre-post dosing compared to those taking the daily dosing, about 52% compared to 75%. And similar to what was said among participants in Harlem, it was hard to predict when sex was happening, and getting that pre-dose in was a challenge. And in this cohort, there were 2 seroconversions among those in the pre-post use group, as well as 2 in the weekly group. And this really, really decreased enthusiasm for an intermittent dosing for cisgender women. And I think we need to talk about how PrEP works to contextualize why there was so much concern about people who were assigned female sex at birth, and why we didn't go forward from the ADAPT trial to more event-driven dosing trials for people who are assigned female sex at birth compared to people who are assigned male sex at birth, where there have been many real-world studies since then. So going back to cells, bear with me, everyone. So PrEP works by when you're taking the TDF PrEP, you get these high drug levels. You can see the drugs in orange and yellow, and it is absorbed into cells, your peripheral blood mononuclear cells, or PBMCs. And it's within those CD4 cells, a type of PBMC, where the drug does its job to prevent HIV integration. And so we know that there is several different ways to measure whether or not we have high levels of drug needed to prevent HIV. And so when, actually, I'm going to go back and tell you a little bit more. So when you're thinking about this, I want you to keep in mind that there's a lot of conversation around that mucosal surface. And there have been a lot of studies taking biopsies of mucosal surfaces, looking at fluid at the mucosal surface, and what are the drug levels right at that mucosal surface, right, and the secretions on that mucosal surface, and looking at those drug levels. Then there's also measures in your peripheral blood in the PBMCs. So based on that knowledge that we all share, we can now interpret several studies that have been done to look at the potential impact of hormones and specifically gender affirming care. And so there have been several studies that looked at the potential impact of estrogens in transgender women who are taking estrogens. And this study gets cited the most as a reason for concern why we might have different efficacy for transgender women who are using gender affirming therapy compared to cisgender men. And so I'm going to orient you all. So on the left of the screen, there are two figures, and those show tenofovir drug levels. On the right of the screen, you see two figures, and those show emtricitabine drug levels. The top two figures show plasma drug levels, and the bottom two show the PBMC drug levels. So I just talked to you about how we can look at the drug levels in multiple spots. And so in the bottom two, the PBMCs, we see no difference between cisgender men and transgender women who are using gender affirming hormones. Looking at the top, looking at plasma drug levels, we see no difference in emtricitabine on the right, and we see a slight difference in the tenofovir drug level at 24 hours in that top left graph. I'm not sure how much that matters. And when we have such a small difference at 24 hours, I think it's important that we have gender inclusive trials and that we continue to measure this. But is this really enough to exclude transgender women from event-driven PrEP, saying that we need higher levels of drug and more consistent dosing to really ensure that people have the protection that they need? Let's talk about the impact of testosterone. A very recent study has come out in the last year that had, again, a small cohort of looking at people assigned male sex at birth, people assigned female sex at birth, and then looking in the right side under people assigned female sex at birth, you can compare people who are not on gender affirming hormones, a small group, 2 people, to people who are taking gender affirming therapy. And you can see no difference in that intracellular, within the red blood cells on a dried blood spot test, no difference for both TDF PrEP and TAF PrEP. So let's take this conversation on where we need high levels of drug a little bit further. A lot of excitement about long-acting injectable PrEP in recent years, and data from cabotegravir suggests that there's efficacy with low rectal drug levels. And there was essentially really, really low drug levels in rectal tissue, but we know cabotegravir works for people who are assigned male sex at birth, people having rectal anal receptive intercourse. So let's talk about in the vagina or front hole, what is happening with the drug levels here. And this is really the basis of a lot of concern around why things might be different in the trials, primarily that enrolled cisgender women, why we're seeing more breakthrough cases. And when you look at the tenofovir drug levels, that middle column, it is much lower in vaginal tissue compared to rectal tissue. Yet, we know that daily tenofovir-based PrEP is proven to be effective for vaginal and front hole sex. A lot of this work I'm presenting is by Mackenzie Cottrell, and she has done some really interesting work recently, really modeling out, what does this mean if the drug levels are low in the female genital tract? And that's what you see, the FGT stands for female genital tract, which is referring to vaginal mucosa or front hole mucosa. And these data show a much lower drug level after 7 days after sex with the 2-1-1 dosing. That's the line in blue on the bottom and the figure on the left, compared to much higher levels in the rectum and PBMCs. And so in the figure on the right, she's modeling, this is a simulation of what if we gave a different dosing schema, 2-2-2, for example. And you see that curve for female genital tract drug levels shifting to the right with higher levels of protection. So there's ongoing conversations of, well, we know that the drug levels for tenofovir are lower in the female genital tract. Do we need to address this with different dosing? Another modeling study, this is a mathematical modeling study that came out just last year. And this modeling study looks at the drug levels from multiple trials, looking at the drug levels in vaginal or front hole mucosa, and the figure on the left, and also looking at the drug levels in PBMCs on the right. So in the model on the left, when you're looking at these vaginal drug levels, and I'm using the language that they're using in their study, that even when you have 7 doses per week, you still don't have an effective protective drug level in the vaginal mucosa. But when you look at the PBMC data, you can see that you have a protective level down to 4 doses a week. You can see high levels of protection at 7 days a week, 6 days a week, and 5 days a week, starting to really dip down when you get to 4 days per week, but still quite high. And I will show you some numbers on that. So thinking about what we know clinically, I'm a little bit concerned about making decisions on how we move forward with what dosing might work well for people having vaginal receptive intercourse or front hole receptive intercourse if we're solely looking at vaginal PK data when that doesn't correlate with what we know clinically. Again, this is math modeling though. We don't have real world data. So let's talk about additional modeling studies. Here are several PK studies, and I show you this busy graph just to really emphasize that there's more and more data being synthesized across prior studies that look at this 4 to 6 doses per week range, and you can see high levels of protection across many of these models, except for the last column here where we're dipping below 80% at 74%, and that's the model using the drug level data in the vaginal mucosa or front hole mucosa that I just showed you from Zhang et al. And this brings me to the question that you are here to hear about, and that is, do vaginas demand perfection? And what I mean by this question is, there has been a lot of conversation that people having vaginal receptive, front hole receptive sex must take 7 perfect daily doses a week in order for PrEP to work for them. However, when looking at the study that just came out this year, where they pooled data from 11 of the Sentinel PrEP trials across 6 countries, they had adherence trajectory data from around 3,000 cisgender women who are in these trials. They saw no difference in people who are consistently taking 4 to 6 doses per week compared to people taking 7 doses per week. And this suggests that when it comes to PrEP, maybe vaginas don't demand the perfection that we have and this higher standard that we've been holding them to. Whenever I talk about event-driven PrEP, people also want to know about TAF, or tenofovir alafenamide, and are there other formulations of PrEP that might be used for event-driven PrEP? And here you can see a model, and this is a slide adapted from Jean-Michel Molina, looking at these really high levels of tenofovir alafenamide, or TAF PrEP, when looking in the PBMCs. And so it's highly protein, it's impacted a lot by protein binding. So those plasma drug levels have made people nervous, but when we focus in on the PBMCs, we actually see a much higher drug level than we've seen for TDF PrEP, which is exciting. And when you think about the potential for event-driven PrEP, there was some studies that have been done in the last couple of years coming out of a large trial. And these show that even with only 2 doses per week, that you have a high level of effectiveness. And so looking at the figure on the bottom left, comparing TAF, and then looking at the figure on the bottom right, looking at TDF PrEP, you really start to see that adherence effectiveness split around 2 doses per week compared to 4 doses per week that we've seen modeled over and over for TDF PrEP. And so this is leading Jean-Michel Molina and others in his group to conduct a trial. I believe it's called the SimPrep trial, and I think they're going to be, and that's ongoing now, and that is going to be a pre-post dosing with TAF. So stay tuned for results on more to come there. So I've just summarized for you the importance of choice, the data on event-driven PrEP, what we know and don't know about the potential impacts of hormones on PrEP levels, and really where we are in next steps for research. So moving forward, we really do need gender-inclusive trials. We need to assess PrEP effectiveness across a broad spectrum of individuals. We can't assume it is the same for everyone. And we need to identify optimal dosing strategies, and this may differ by sex and gender. I also would like to suggest that we take more of a harm reduction approach to PrEP. Choice is trauma-informed care. And if someone wants to choose event-driven PrEP, even though their coverage is lower, some PrEP is better than no PrEP. Thank you so much.
Thank you, Jenell. That was really a beautiful talk. So appreciated. You can go ahead and stop sharing your screen. When you have a second, we can see everyone's faces. So we've got about 20 minutes for QA and discussion. There has been a few questions dropped in the chat, comments in the chat, but I'm going to see first if anyone wants to raise their hand and come off mute and come on video and ask their question. And while you're getting warmed up, I have a few things I want to query Jenell about. So one thing that's been driving me crazy, and I'm sure lots of people in the field crazy for the last several years, is the difference between CDC guidelines and WHO guidelines. So several years ago, WHO talked about time to protection for cisgender women for vaginal protection being about a week of dosing. But the CDC has been saying 3 weeks of dosing for time to protection, and they're looking basically at the same data. So I know you're not like responsible for this.
Definitely not responsible.
But can you speak to that? Like, what is happening here? Lots of smart people are looking at the same data and coming up with really, really different conclusions. And so before we even get to event-driven PrEP for cis women, people with vaginas, front holes, this sort of dissonance between time to protection, telling some if you're in America, you're being told you got to take the pill every day for 3 weeks before you get protection. If you're in the rest of the world, you're being told you take the pill every day for a week till you have optimal protection. What is up with all of that?
Well, guidelines are slow to change. That's the first response to that. There's a need for the guidelines to be updated, and CDC knows that, and they are working on it. I think I'm hopeful that we will see updated guidelines in the near future. I think I would take that one step further, Jim. We have seen in the UK a double dose start to daily PrEP for people who are assigned female sex at birth. The IAS also recommends a double dose start. I would love to see more options that align with what people need. If people are highly sexually active and they need that PrEP to work tomorrow, how can we use PrEP smarter to meet people where they are? And so I would like to see more investigation into the possibility of a double dose start for those who might benefit from it.
I agree, and thank you for bringing up those other, even more, other different recommendations for
All over the place. Yeah.
all over the place. And so it's really confusing for people in the
Yes.
field. Like, what would you recommend? So you're a nurse in Texas in the United States, and you're looking at all of these different recommendations, and you have what the CDC says and the US FDA says, and then these other very reputable groups, and you have a person sitting in front of you. I know you talked about, a harm reduction approach and choices, trauma-informed care. What would you recommend to that nurse sitting in front with a cisgender woman sitting in front of them, exploring what PrEP might look for them in their life?
Yeah, I think one of the things that's a big challenge with science communication right now is thinking about population level advice and individual level advice. For a big organization like CDC or WHO to come up with guidelines, they need to think about a population level advice, making sure that they're coming up with something that kind of fits everyone, making sure we're triaging resources, all those things. But when I'm sitting with my patients as a physician in Minnesota, and I am helping them decide how to approach PrEP, it's about the person in front of me. And so if they're telling me, I'm a sex worker and I need PrEP to work today, I would say, I know they're going to have sex anyway. I could tell them to wait whatever the CDC guidelines say, but that's not realistic. That's not the person sitting in front of me. And so I could say, I can't 100% guarantee that a double dose is going to be effective for you, but it feels safer than telling someone not to do something that they're going to do anyway. And then they have to have the guilt and shame of disappointing their doctor, in addition to not getting better medical advice. So I would not hesitate to tell someone about a double dose start based on what's being done in other countries.
And this is why you're one of my heroes. This sort of very, humane approach, and looking at people as individuals, and understanding that. I think this is where you're also kind of going, and which has been something we've known in the contraceptive field for a long time, that effectiveness or efficacy isn't the only thing that drives people to choose a certain kind of option for contraception or for PrEP, that options need to fit into people's lives.
Absolutely.
And just because an option may not be 100%, or you can't guarantee that, doesn't mean it's not a good option. So if someone is getting an option with 60 or 70%, let's say, essential effectiveness, that's so much better than zero effectiveness.
Exactly. And that is I feel ready to have those conversations knowing the data. And I think it would be really intimidating if you weren't at the nerd level that I'm at, where you're spending your evenings reading through all of these primary papers. And so you really do need the guidelines to back you up. And so I really hope that the guidelines can continue to be a little bit more responsive to making way for for shared decision making. And we've seen that in more recent guidelines, the Doxy PrEP guidelines, for example, where the Doxy PrEP guidelines say, we have data for cisgender men, transgender women. We don't yet have data to support use for cisgender women, but with shared decision making, this should be an option. And so I'm hoping that we will continue to see more guidelines coming out that leave that option open for shared decision making while we're waiting for the science to catch up.
I know the CDC and the wonderful Dr. Rupa Patel at CDC are working on the revision of the CDC guidance for PrEP. Do you have any sense, do you have any inkling of when we might see these revisions coming?
I would never dare to predict the timeline for guidelines. I think we all know that even those who are making the guidelines are frustrated by the pace. There's just, because it's population level guidance, it needs to go through many levels of review and scrutiny. So it's not going to happen as fast as we want it to.
I figured that was the answer, but I thought maybe you might have a little bird that's been telling you, giving you updates.
I mean, I know they're working on it.
Yeah.
That's the inside scoop I can offer you all.
And I definitely hope it does move towards this more kind of shared decision making, harm reduction, offering choices for all genders, because right now the guidance doesn't do a whole lot around event driven for anybody. And obviously, event driven is pretty important for folks.
Yeah, and I didn't really get into the differences between guidelines, but I will say that there are several countries that say if you're having any form of anal sex, regardless of sex and gender, that event-driven PrEP will work for you, which is a really interesting interpretation of the data, the same data I just shared with you, where we're not seeing that in all settings. And we're seeing all transgender people, regardless of their sex assigned at birth, being included in event-driven PrEP. Which is, again, a really interesting interpretation of the same data that I just presented to you. So I think it's about, I applaud those making guidelines that are attempting as much as possible to be inclusive when the trials themselves were not inclusive. And so I'm hoping that we have more inclusive trials to support those making guidelines.
And thank you so much for making a plug for that. We can definitely, I think all of us should get behind more inclusive trials and including people of all genders and all persuasions in studies so we can make much better informed decisions about guidance, etc. I could keep going here, Jenell, but I'm going to just pause and see if someone wants to raise their hand, has a question or a comment based on this conversation or anything Jenell has presented. Please, I know there's a lot of people in here who are not shy. I see Sheena raising her hand the old-fashioned way. I love it. Sheena, come on.
I'm so sorry, Jim. I don't see, usually under reactions there's a raise your hand, but I can't see it. But first of all, Jenell, thank you so much for a fabulous talk. I wanted to just say there's another part of the anatomy we don't talk about much, and that's the foreskin. and that's another part that's not unlike the female genital tract in terms of its levels of drug. And yet we know it works for foreskins from all the trials in cis men. So I was really, so pleased to see the more recent data from the mathematical modeling and the updates from the PK PD that really suggests that what's happening in the PBMCs is so important. And what's going on perhaps in our genital tracts only really matters in a very short space of time. And I wondered if I could put you on the spot there and say, how long do you think it matters for what's happening in the genital tract? How long do we think the PBMCs take to actually get there and populate what you need in the genital tract? It's probably quite a short space of time.
Sheena, are you talking about prior to exposure to HIV, or how long after exposure to HIV do we need?
It's kind of both. If you want to address both, that would be great, because we haven't also even touched on how out of date the PEP guidelines are.
Yes, I mean, if I had even longer presentation, I would dive into the PEP guidelines, which could very much use an update and use more science behind it. I think based on the modeling studies, I think it's pretty quick for PBMCs. I think, and that's why that 2-hour window is I think there for the 211 PrEP. And I would love to see more data on even shorter periods of time, because I know people are using event-driven PrEP with a shorter window than 211. Than the 2 hours before. And so I would love to see better data on that. And then and how long after? It really looks like it might be 7 days, but I'm sure there are experts that can have that can fill me in on better data. Sheena, I actually suspect you might know the answer to this. What can I push this back on you and ask you what your hot take on the how long before and how long after?
So I find it yeah, I mean, I kind of agree with you. I sort of appreciate maybe you might need it, the sort of the transmission experts get very fretful about the cells that replicate very slowly. But I totally agree with you. I don't think there's very much viral replication happening in the first 24 hours at all. So any drug you take in that 24 hours around exposure, within exposure, so this isn't even talking about post-exposure prophylaxis, is going to be super valuable. And I think the data I've most questioned is how valuable is giving the drug 72 hours later, which is what we do with post-exposure prophylaxis. Right. So the message, I think the population message I'd really like to get out, and the message for the individual too, is that drug you take in the 24 hours around the time you have condomless sex is the drug that matters, whoever you are, whatever sort of sex you've had. That's what really matters.
Absolutely. Yeah. And I think I'm excited for what's coming next now that we are not solely focused on the mucosal surfaces, but really paying attention to those PBMCs as well. And just for everyone else in the room, I don't want to oversimplify the importance of PBMCs. The microbicide trials had high drug level at the mucosa and low PBMC drug levels, and we did see some efficacy. So I think there's still something to be understood. I don't want to say that PBMCs are the only answer, but I think that correlates a lot more closely to what we're seeing clinically, which very much matters, compared to what we're seeing in the mucosal drug level data.
Yeah, and I think you're right in drawing attention to the long-acting drugs, particularly cabotegravir, where you don't get very much in the genital, where you get very pokey PBMCs. So you're right, it's a backup. It matters first in the genital mucosa for sex you have there, but after that, yeah. Anyway, thank you for
you,
that.
Sheena.
Thank you for drawing attention to the UK guidelines. They're actually going out for public consultation very soon. So Jim, I could send you the link to that when they go out.
Oh yeah, thank you so much, Sheena. And speaking of double, Jenell, a few people have been asking where they can get some good information on this double dose start that you mentioned. Is there a link we can share, or somewhere we can point folks?
That's a great question. I would send them to the UK guidelines because I feel like that is where that approach is more widely accepted. And then, and I think that the data behind it is really pulling from the ePrEP and Prevenir studies, what we know from 211 dosing and the pharmacokinetics behind that. I know IAS has also endorsed a double dose start, but it feels like it's a small mention, a single sentence. So I don't know how much more information there is than that.
And can you also, I think, and Lawrence, I see your hand, so you're going to come next after we get this kind of follow-up question about double dosing. What is double dosing compared to 211 dosing? Like, how do you differentiate that? So that's part one. And then part two, someone in the chat, I think rightly brings up, can we have one way to describe event dosing? Like 211, event dosing, like it kind of gets confusing and it sounds like they're all different things. So what do you think about a standardized way of speaking about 211 or event? And then can you just differentiate between double dosing, a double dose start, and regular 211?
Yeah, so when I'm talking about a double dose start, I'm talking about 2 pills of tenofovir disoproxil fumarate, the TDF PrEP, because we don't yet have data on TAF for event-driven dosing. A double dose within 2 to 24 hours of sex, followed by daily dosing. And per the event-driven guidelines, until 48 hours after your last sex. So for some people, it's going to be 2 pills, and then you just stay on that daily dose because your sex is a regular part of your life. And so it's going to be 2-1-1-1-1-1-1-1-1-1-1 until, years from now. For others, it's going to be a double dose and then only those 2 doses, because sex for them is more of an intermittent activity, and they don't really need to stay on this daily dosing in between. So I'm really just talking about extending event-driven dosing into daily dosing. And that's what I'm talking about with that double dose start. And Jim, you had other questions for me. There were layers of questions. What am I?
Yeah, and then Lawrence will get to you, and then I know Jenell has to leave at the top of the hour, and we're going to move on to our discussion or our meet and greet with Anna Miti. But what do you think about coming up with one way to describe 211 or event dosing? It starts to get a little bit confusing for folks.
It is confusing, and I worry about. I think 211, it makes sense to people. It helps them remember what they need to do, the number of pills, but that's probably going to change. There's probably going to be new ways to event-driven dose. If we have new TAF, that's one before and one after, that's going to be confusing. We're going to have, and who knows where we'll end up for people having vaginal receptive and front hole receptive sex. Is it going to be 211 or will it be 221? I don't know yet. And so I think I like 211, but I worry about oversimplifying. So I don't have a good answer for branding. I think we need to talk to someone in advertising, maybe a TikTok influencer, on how to rebrand these things so that it makes more sense. And I think in an era of doxy PEP as well, where we're talking about something that's only after sex, that's also event driven, I think we really could use some branding help. I'm not a communications expert. I wish I were.
So comms folks, advocates who are interested in this, we have some work to do on branding. Lawrence, thank you so much for your patience. Go ahead and come off mute and ask your question.
Okay, thank you very much. And I think this is just a phenomenal presentation, and the information is absolutely useful. One of the questions that I want to talk about, particularly here in the United States, and more specifically around the southern part of the United States, in terms of PrEP uptake. And so that is an issue in many underserved communities, particularly in rural areas. So what I wanted to know, and I'm not sure if you may know about this or not, but one of the trajectories is to allow pharmacists to prescribe PrEP in an effort just to make it more available throughout communities, as opposed to having to go through your provider. So wanted to know if you could speak to that, but also what some of the barriers may be in accessing PrEP through pharmacists.
Yeah, thank you so much, Lawrence, for bringing this up. I feel passionately about the importance of decentralizing PrEP care. You shouldn't need to go to a specialty clinic to get PrEP. PrEP is safe. It is very easy to prescribe. I'm seeing pharmacy delivered PrEP around the world. We just here in the state of Minnesota, where I am currently sitting, we have pharmacy PrEP in our legislature. I've been collaborating with investigators in Kenya who are rolling out PrEP in pharmacies in Kenya. And it's incredibly important. We do not exist in a vacuum. There's still a lot of stigma around using PrEP, and that varies depending on where you are. And I think rural areas are hit a little bit harder by some of those social barriers to getting on PrEP. And especially if you have to drive a long way to see a provider and that provider doesn't do a lot of PrEP care, they might not be comfortable. But I think coming up with really straightforward pharmacy guidelines for getting PrEP out there is going to be great. And I think a big step in the right direction.
Thank you very much. Absolutely phenomenal.
And I know, Jenell, that you need to leave. It's the top of the hour. So if we could give everyone, give Jenell a virtual round of applause. You could do it the old-fashioned way like Sheena and I are doing. You can use your various emojis if you can figure out where they are. I think part of the issue, Sheena, is they keep moving them around. And there's been some updates on Zoom, and I also have a hard time finding all these things. But we can see lots of people have found the hand. So very, very good. Thank you so much, Jenell. It's been a treat. We would love to have you back as these things develop. And thank you for letting me chase you down and stalk you for the last, I don't know, 8 months.
Anytime, Jim.
So thank you, thank you.
Okay, thanks everyone.
And now I am so delighted. I'm going to add Anna here to the spotlight. As we have mentioned, Anna Miti, starting today, is a new, our very first ever Choice Agenda co-moderator. She's going to be joining me, helping me manage this growing list and this growing discussion that we've been having for the last 2.5 years, and also helping me program webinars like this going forward. So delighted to have Anna join the team. Be part of my team. And this is an opportunity to get to know her a little bit better. So Anna, first of all, thank you for applying and going through all the steps that you had to go through to get to this spot. Why don't you, I think there's a lot of people who know you quite well and some people who are just getting to know you today. So why don't you take a few minutes and give us a little bit of background about who is this person, Anna Miti?
Thank you so much, Jim. And I'm absolutely excited and a little bit nervous, but that's to be expected. This is a very big forum, and I've been following the Choice Agenda for a while now, I think three or so years. And, I'm so delighted to be here. I started my career as a broadcaster, working for the Zimbabwe Broadcasting Corporation, which is like the public broadcaster here in Zimbabwe. So I'm a journalist by training. And I was doing a lot of science programs, a lot of health programs on radio. And as I always say, I got bored, of asking questions, which really didn't have answers when it comes to HIV and AIDS, especially because we would go into the communities, would see something happening, and then you bring a guest over on radio and they're, maybe they're an official of sorts and they are saying completely different things from what we're seeing on the ground. So that's why, I got an opportunity to be in touch with some AVAC fellows that were in Zimbabwe, Chamu and Munya. And they told me about this interesting fellowship, AVAC Advocacy Fellowship, and I applied for it. And by the grace of God, I actually got it. And so 2015 to 2016, I was working on, that was the time when there was the PrEP studies the PrEP ring studies that were done in Zimbabwe and, in other parts of Southern Africa. And so my project was looking at raising awareness of those studies to adolescent girls and young women, and also to other HIV advocates, because at that time, research was really guided. It still is. And you'd find even advocates in the HIV sector would tell you, I've actually never heard about the PrEP ring study. And then, we got into doing that. And I was also working with journalists. The AVAC Fellowship actually opened my eyes to a lot of information, a lot of spaces that I got into. But then I realized that as a journalist, there are not many journalists in these spaces. There are people who are great information that would love to have this information out there, but they don't have this platform. And frankly speaking, some of the researchers were quite afraid or, nervous or hesitant to talk to journalists because a lot of them had actually never met a journalist. And so I got the idea to work with journalists in Zimbabwe And with the help of a lot of other people, I founded the Health Communicators Forum of Zimbabwe, which is a network of journalists that are involved in HIV reporting, science reporting. And so we get to meet regularly to do this.
I'm
So we're
gonna find them. I'm gonna hold on. There we go. Sorry, Anna, go ahead.
all right. So I started working with the Health Communicators Forum of Zimbabwe, and now that's kind of the main thing that I do. We've got what we call media science cafes with support from, I saw my tribe earlier, Kay, Marshall, Angelo, I saw Bridget. And so we do this media science cafes regularly. We invite researchers, we invite other stakeholders, advocates, community members, and they come through, they talk about, we come up with the topic and we get all these different angles, and the journalists are in a space where they can ask questions. I know, like, for example, Jenell's presentation, the journalists were here, there were a lot of questions about the figures and would say, we want you to understand this, and we try as much as possible to, not to dumb it down, but to make it easier for journalists to understand, because, we're not all clinicians. So that's kind of the work that I've been doing. I've also done a lot of community work around HIV, biomedical HIV prevention work with the International Partnership for Microbicides, working with adolescent girls and young women, and over the last 2 years, working with adolescent boys and young men as well. And yeah, that has been quite a ride. And I did warn you, Jim, that, as advocates, we love to talk and talk and talk. So yeah, I'm going to pause there.
We definitely love to talk. I agree. I'm gonna just, as Anna and I are talking, this is a casual conversation. We would love anyone to jump in if they want to say hello to Anna, ask Anna a question. Please feel free to raise your hand and we will have you come off mute. You can also leave some comments in the chat. I see a number of people have welcomed Anna in the chat. So let's keep this conversational. It doesn't have to be just me and Anna talking, but as Anna mentioned, we love the sound of our own voices, so we could easily just fill this time. Thank you, Angelo, for the really nice comment. Welcome home, Anna. We belong together, so yeah, I think we do. I think this is going to be a good match. I'm super excited. I know we've talked about this, off this webinar, obviously, Anna, but what are you hoping to kind of bring to the discussion in terms of the choice agenda list and bring to our programming ideas in terms of our webinars? What ideas do you initially have to sort of give us some more oomph, improve what we're doing, expand what we're doing? And I agree, Kay, Anna definitely rocks.
Thanks for the nice comments, guys. I'm blushing now. You can't see it. So one of the things.
Did someone want to say something?
Apologies, this is Neetha here, so I've been struggling, but Anna, finish, and then I'll ask my question.
Okay, so we will put you on hold there, Neetha. Thank you so much. Anna, go ahead, and then we'll have Neetha come next. Thank you.
All right. So I was going to talk about how there's a lot of science that is out there, and it covers a whole range of things. When you think about the HIV sector or HIV research, there's new things like just a couple of weeks ago, I was in a webinar talking about BNABs, broadly neutralizing antibodies, and in children, like in young babies and small babies. And this is like a very new field because we've had, and like Jenell said, there are some of those populations that have kind of been forgotten about. Of course, it's important because there are ethics to it and things like that. But children and pediatric HIV, it's been like a bit of a neglected area, which is why even you find that in terms of uptake of ARVs or ART, even in terms of viral suppression, pediatrics, it's really lagging behind. So there are some of those for kind of, not so much in the spotlight that I would really want us to discuss because they do affect us. And I also love to bring people with more lived experience. I love the scientists, I love the science, but there are some people who have lived and gone through this journey. For example, when we talk about aging with HIV, it's a new thing that people are talking about now. about people who've been taking art for over 20 years, and what are some of the things that science needs to be looking at, and someone was reminding me that whenever we talk about, and you see it in the data, when you're talking about studies, it's between age 18 to 44. And you kind of like, if you turn 45, are you certainly immune to HIV? Why are we not studying people who are over 45? Things like that. So I'd really love that. And you're probably going to see a couple of my tribe in terms of the journalists, because the Media Science Cafe program is in like 6 different countries. So you might also get to see some of my tribe coming through, and I really want them to come through because they also have kind of a different look when it comes to the questions. So that's something that I'm looking forward to. Yeah.
And I would love that. You may have missed this, but while you were chatting, I put in the chat links to our webinar that we did on the Media Science Cafe that featured you earlier this year. It was such a great conversation. And you're right, and kind of understanding where journalists are coming from as sort of everyday people who are not researchers or advocates, but trying to understand and communicate complex science and important science. It was really fascinating. So I would love to see some more of that flavor brought in. So I'm excited that you're thinking about that. Nita, are you ready to make your comment or question?
Yes, hi. So thank you very much. And firstly, really congratulations to the Choice Agenda. It's been such an excellent resource for science and sharing those articles. So well done. And really welcome, Anna. It's exciting to have you, both from a regional point of view, but also from just a journalist point of view. I know for the PrEP trial, we learned a lot by having Kay Marshall host a media cafe. And in fact, we want to follow up. But my comments, suggestions are threefold. The one is that, we also need to ensure that the language of stakeholder engagement and community engagement is communicated adequately, because there's a gap. And it's not just unpacking the science. And I would really like us to invest in that, because one sees the gap in the language and understanding of these difficult concepts for the scientist and the researcher. So I'd like us to focus on that moving forward. I think the second is that, we have such limited resources and everything is important or critical, but it will be really nice for us to reflect maybe towards the end of the year or in January as a Choice Agenda group. Where are we and what are we focusing on in terms of prevention, treatment, and care? And where are the resources? Are we moving towards the resources and answering those questions? Or are we going back and taking lessons in the context of, say, the cultural, social dynamics of what impacts on some of these biomedical prevention? So that's the second point comment. And I think the last is that one of the things I'm finding, having been in the field, is information sharing versus critical understanding and analysis, and what is the call for action? Because we tend to then just forget about that, and then it's the next webinar, the next talk. And I'd like us collectively, I'm also responsible for this, is to move towards call for action within timeframes. Thank you.
Those are really excellent comments. Well noted, Nita. Anna, do you have anything you want to respond to in terms of what Nita was saying?
Just to really, really agree with Nita, I'll give you an example of those concepts like HIV cure. I know we actually had a really bit of a back and forth with the researchers. If journalists say a person has been cured of HIV, and they would say, no, it's not cure, it's remission, because we don't really know, even if it's 20 years, what if they, they say, it comes back after, on the 21st, and there's always that issue. And I think that just to also agree with you, especially on language and communicating in the field right now with event-driven PrEP, we've been telling the women, PrEP is not forgiving for women. We need to take it. You need to adhere to it every day. Take your pill on time, at the same time, every day. And now we are moving to event-driven PrEP. It's going to be one of those things that we really, really need to work hard on communicating and making it simpler and making it, you know, understandable to the people to say, if you can, we want you to, you know, you are rather safer if you could do this, but if you don't then just give up completely. I don't know. I'm not an expert, but in terms of communications, I think it's collectively, we really have a lot of work to do. And also, again, yeah, beyond the webinars, what do we really also want to do? One thing that I've noticed, though, I mean, it's good to do the webinars because we get to think about those things, and perhaps, you know, we will have at some point, and we keep having these discussions, and I'm very excited, you know, to really think about what we want to focus on, what is the next step, what do we do after this webinar? Yeah.
So thank you for that, and invite anyone else to raise their hand and join in. And I will direct you to a comment that Shakina, who's a longtime TCA member. Hi, Shakina, nice to see you. I'll put in the chat. She's interested in connecting you with some journalists she knows in East Africa. So maybe offline, I can make a connection with you two. I'll do an email introduction, and then you all can take it from there. And Shakina, if you want to add anything, I see your face. I see a beautiful new hair color. I haven't seen this. It looks like it's fresh and new. So if you want to come on, good. I lured you off
All
mute.
right.
Go ahead.
I'm multitasking. I'm listening to the UN as well as another webinar.
Oh my goodness.
Yeah, it's a bit like that some days. So, yeah, I have a collective in East Africa that have been working with me to try and get me to provide some training specifically on language. It's a big lift, as you know, and the diversity in all of Africa, you know, language is so vast and diverse that I often wonder, within the context of our conversations in our webinars, how does that get translated to remote areas where, you know, hundreds of languages, dialects are spoken? How does that all get translated, and who is able to actually deliver the messages? Is it you, the journalist? Is it community outreach people? Who's actually doing that work? Because I'm starting to identify through people who are reaching out to me that they're completely alone and lack understanding. And without us in this room sharing our knowledge and experience, there would be nothing. So I'm just kind of curious if there's a need, for one, to be able to, you know, we talk about meeting people where they're at all the time. And I'm constantly finding new ways to do that. And so as I look at language, the impact on stigma, I'm getting ready to write a piece too on stigma. I've been motivated by a few people that have really triggered me. And so, do you have any thoughts on that?
Yeah.
Thank you, Shakina.
Yeah, actually, I'll just go right ahead. Thank you so much, Shakina, for that. It's brilliant. It's a very brilliant question. And it speaks to something that we kind of started with the AVAC and the Media Science Cafes. So I'm not sure who you work with in Eastern Africa, but we've got TAMA in Tanzania. We've got HNU in Uganda. We've got also Mesha in Kenya. They are groups of journalists. But please, you know, feel free to reach out to me, and Jimmy can do the introductions. So we started something really exciting with support from AVAC, which was looking at translating some of the HIV or science research terms to local languages, like not just simpler English, but local languages, you know, and it was over 6 different countries. For example, in Zimbabwe, where I work, we've got Shona and Ndebele, which are the main languages there. And it's been great. So they were working with people who are experts in language, translating that, and then getting it down to, you know, people talking about HIV in vernacular. And it's very true that there are some areas that in Africa where we see people, you talk about PrEP and someone has never heard about PrEP. Now we are moving on to event-driven PrEP. We're talking to different types of PrEP, injectable PrEP. We're talking about 2 different pills, Descovy versus FTAF and all that. But these people have never heard about it. And if they've done so, it's kind of like not in something that they understand. So it's going to be a long walk, but I think we should really, keep on working, keep on doing so. And I think journalists are really at the best place to do that, because ordinarily we do have journalists that report in those languages. So they are used daily. They translate big breaking news and they translate it already to languages that their audiences understand. So I think that's great work that is started there. It's still, it's something that we did, I think, last year. So we'll continue even updating those terms, as more research comes, there's more terms that comes. How do you say BNABs in Ndebele or in Shona? It's very difficult. And talking about that as well, if you're going to R4P, Esther Nakazi, you might know from Uganda, has got a presentation where she's going to be talking about language and how language has transformed, the way they talk about, the way they report on HIV science. So that's something to look forward to during the R4P conference. Yeah.
Thank you,
Thank you.
Shakina, for that, and thank you, Anna, and thank you for reminding me. I'm going to R4P too, and it just occurs to me that there will probably be a lot of inspiration at R4P for future webinars. So we'll be looking at content very carefully at R4P, and we may see some things that are inspired from that conference coming up on our agenda for the new year. And the other thing I just wanted to underscore, and then there's a comment that came in directly to me, Anna, but you were mentioning, all the work we need to do, to sort of help educate and communicate about event-driven PrEP for cis women, or this idea that PrEP is much more forgiveness, has much more forgiveness in terms of cis women and vaginas than what we originally thought. And I think it is a really hard thing, right? I mean, we have these messages that get really baked in, and they're very hard to undo. Just like when we first saw PrEP come about, after decades of saying condoms were the best form of protection and condoms were everything, and if you don't use condoms, it's unsafe. And we had to undo a lot of that to expand our thinking about what safe sex was. It wasn't just about barriers. It could also be about pills. And we're still kind of dealing with that. So I think undoing sort of the years of dogma about vaginas aren't forgiving, when in fact we now have evidence that they are, it's going to really take all of us to really be undoing it, to make sure that we have that we see outcomes on the ground, that more people are willing to take up PrEP, knowing they don't have to be superstar adherers, like adhering like no other human being can adhere. That's sort of the message we've been telling cis women and people who have vaginal sex, like just asking them to sort of reach a bar that's unattainable for most humans is not fair, and it's now not based on science. So a lot of work to do there, and thinking about kinds of PrEP. And this is a comment that came in from Paul Ahrens. He just wanted to, what your thoughts are, Anna, on injectable PrEP. I know injectable PrEP, injectable CAB has started to roll out in Zimbabwe, if I'm correct, and through a number of other southern African countries. And now we're looking at lenacapavir right around the corner, potentially going, a twice a year injection. And that's something we could start to see, become approved next year and start rolling out sometime thereafter. I hesitate to say soon. Nothing is ever soon. It's always complicated. But what are your thoughts about injectable PrEP in general, and the advent of what adding lenacapavir to our collective toolbox might mean, particularly for cis women where you are in Zimbabwe in Southern Africa?
Right. So I'm thinking of 2 things. The first one is that we, like the choice agenda really says, we have to remember the choice. And when you look at next steps on what we need to do, I really think about issues of advocacy around remembering the choice. You know, we have a challenge where whenever you've got something new, you know, politicians, you know, the decision makers kind of want the easiest thing. At this moment, it seems like learn will be the easiest thing, you know, 2 shots, you know, per year, or you know, 2 visits to the clinic per year, and that's it, rather than seeing you every 2 months or every 8 weeks with the injectable cap. And I fear, because when we had when the results of Aspire and other, you know, PrEP ring studies came through, our government went ahead and approved the PrEP ring. And because people kind of, just around about that time, then PrEP came through, oral PrEP. And people were like, oh yeah, well, this seems better. You know, this got more efficacy. It's easier to do this. There's more funding for it. There's more support. So, you know, they kind of want to move to the next best or the next biggest shining thing that's there. So my thoughts on injectable PrEP is that, yes, it's a game changer, but it's good to remember the basket, to remember that all this has to be in that basket, and all things that they really have to work together. Otherwise, it won't really work. There's no one size fits all at all when it comes to HIV prevention. And the second thought is on advocacy around the issues of pricing, the issues of access. That's Len, as much as I'm excited about Len, I keep remembering that when I was doing my AVAC advocacy back in 2016, you know, the government said, yeah, we're going to have oral PrEP as well, you know. And up to now, when we are in 2024, I can tell you that as much as the guidelines say anyone who needs oral PrEP, anyone who's at risk should access oral PrEP, there are a lot of places where people actually still don't know much about it, you know, or even access it. There are many, many barriers that are there on it. But Len, I think the biggest thing is going to be pricing. There is still need for a lot of advocacy around pricing, a lot of advocacy around access. But as an advocate, I'll always say, please remember the choice. You know, even event-driven PrEP is not a choice for everyone. Someone would rather have, you know, the adherence because thinking of taking the pills just before, you know, maybe their boyfriend is out of town, they stay somewhere. As a cisgender woman, you start thinking, okay, maybe I need to take it before, you know, the partner comes, and you have to remember this. Others would just rather, you know, because it's like that. Some people would rather have the ring, just put it in there and forget about it. Some people, a shot that is going to last 6 months in your system, when we've been told all sorts of, you know, there's a lot of anti-science that's there. It's not going to be a walk in the park to introduce Len, definitely. But we need to maybe start thinking about these things as advocates and anticipate, you know, what sort of actions we could take. And for me personally, my thing is advocacy already with the stakeholders about choice. Let's not forget about other things. This is cute. This is nice. We want it. Let it add onto the basket. Yeah.
Yeah, I so agree. I get really concerned with chasing the shiny new thing, and oh, we don't need to talk about that other thing because this thing is, quote, better. That's, you know, that's BS, right? Because what's better is the thing that works for that person. And if someone doesn't like shots, is afraid of shots, doesn't like needles, like that doesn't matter. Like if it's 100 bazillion% effective, like if you don't like needles, it's 0% effective. And these other things are still really excellent. So I think we all need to be careful to not sort of, you know, put a yuck on other options that might be perfect for someone else. Maybe the vaginal ring may not be for you. You may not like that idea. You may not think it's appropriate for you, but there are people for whom it is very appropriate and who do like it. And I think those of us who are advocates and people working in healthcare and policymakers, all of us need to keep, like you said, that basket, right, in mind, and that everyone should, as we're not shrinking the basket as new things come out. We're expanding the basket because, in fact, the basket still includes condoms. And condoms, internal and external condoms, are still used by people. And there are people who still like those options and choose those options. So we may not talk about them as much anymore because they're not necessarily new, but they're still important. And we don't want to like throw those out because we have something new and shiny. And the last thing I'll say is just around pricing. And so you're absolutely right. Like the cost of these drugs really, really matters. And I know there's a lot of discussion happening about making lenacapavir price appropriate for Southern Africa and other parts of the world. I also just want to call in the United States. We pay a lot of money. We pay the most money of anybody for drugs here. And cabotegravir is priced right now way out of line. It is so high. It is one of the reasons why we've had very slow and poor uptake of injectable cab in our country, in the United States. It's been available, but is it accessible? No, for a lot of people, it is not. And it's a couple of things. It's a complex regimen. It's complex to deliver and it's complex to receive, but it's also priced extremely high. And so I think there's a lot of concern in the United States that lenacapavir, will be priced very, very, very high, and that will make it very hard for insurers to cover it, and then therefore it will really, really circumscribe and limit access. So hoping that the drug makers will choose pricing that still gives them a very nice big profit for their shareholders, even at much lower numbers than what we are anticipating, and can get it out so we actually have public health impact, and that these interventions are not just made available to a select few privileged folks who are, through luck and circumstance and geography, are able to access these things. We're seeing, serious issues with CAB everywhere, and certainly, and here in this country, and unless we get our hands around this pricing issue, I think we're going to see the same thing with lenacapavir.
True. And also, Jim, even in the United States, remember there are pockets of different, people with different access to different things. Like not everyone is on the same income. So even if the US is classified as a high income, there are communities that still need access to CAB at, nominal pricing or even for free.
100% agree. 100% agree. I think for any kind of PrEP, personally, I think for any kind of PrEP to have any real strong impact, it has to have a $0 impact on the individual's pocketbook. Public health, other places need to pick up the costs that are entailed by these interventions. But if we're putting price, if we're making the individual bear the responsibility of paying something, we know that even once you pay, even what we may think is a nominal amount, $1 or $2, can be a deal breaker for a lot of people, for whom $1 or $2 might mean they're hungry or not that day, or that they are able to make their rent that month. If they're, if they're making choices between an HIV prevention intervention and their well-being, their livelihood, their ability to stay in somewhere safe, their ability to have a full tummy, etc. Like, we know what's going to win. HIV prevention is not, and that's a really unfair sort of situation to put people in, anybody in. So these interventions should not be just for people who are privileged with access to the money and resources and insurance that may cover these things. We need to make sure that this is covered for everybody, and that your ability to pay is not in question at all. So we'll see how that conversation goes. We've been struggling with this since we've had PrEP, because oral PrEP has been, priced out of reach for a lot of people. We're now, when we're looking at these injectables, it's just sort of like pricing on steroids. It's so expensive and complicated, and it may be a game changer and a revolutionary in the scientific realm, but it won't mean anything if we don't get it to people. It'll look good in a journal paper, but if it's not reaching people who need it and making and everyone who needs it having access to it, real access, then we've collectively failed. So I know we're kind of going over a little bit here, Anna. I'm going to give you the last word. We're a few minutes over, so why don't you, whatever, what are your words of wisdom for today? What do you want to leave our audience with? What are you looking forward to? I don't know, today, this week, whatever you want to say, Anna. Last word is yours.
Right. Heavy. But yeah, my final remarks are just, I'm so excited to be here. There's going to be lots of exciting times ahead. And I'm really looking forward to all your thoughts, all your views, comments, and this really is a vibrant space, and it is a safe space to discuss these things as advocates. And really, every everyone of us who's here and those that are on the choice agenda are there because they are working, in all these things that we're doing in the HIV prevention space, and other health concerns, of course. So we're all important, and all of us, we have a contribution to make. It's about all of us. In Zim, we've got this thing about HIV being everybody's business. So health, science, research, HIV, it's everyone's business. And so I'm glad to be here, and I'm glad to connect with all of you. Yeah, that's my remarks.
Thank you, Anna. So let's give Anna some love, some hearts, some hands, some rounds of applause. So delighted to have you on this team. Thank you, thank you, thank you. I dropped in a link to our next webinar, October 24th, looking at providing PrEP in correctional settings. A super exciting topic, a difficult and complex topic. We hope you will join us. We hope you will be joining us on our various webinar programs, as well as the list. And you will start to see more and more of Anna coming forward. Today is her first day. She's easing into this, but you'll start to see Anna a lot more. And again, so thrilled, Anna, to have you on the team. Thank you so much. And to everyone else who's been with us today, thank you for hanging out. Thank you for hanging out for a few extra minutes. I'm going to officially close the webinar now, and we'll see you online. I look forward to seeing some of you in Lima at HIV R4P, and certainly on a webinar coming to your screen soon. So take good care, and bye-bye.
Bye, everyone.